Hello everyone and welcome. I'm Dr. Lynne Varga, and today we're going to talk about something that many of you may already be encountering in your studios, your rehearsals, your own bodies perhaps, often without having a clear name for it. And this presentation is about hypermobility, how it shows up in singers, and why voice teachers need to understand it, not as a niche diagnosis, but as a common, under-recognized factor that can directly impact vocal function, stamina, consistency, and long-term vocal health. My goal today is not to turn you into medical professionals. My goal is to give you context, language, and practical awareness so that when hypermobility shows up in your teaching or performing life, you can recognize it, respond appropriately, and most importantly, do no harm. So, off we go for the presentation here. Before we begin, an important disclaimer. This presentation is educational, not diagnostic. Nothing here replaces medical evaluation or individualized care. Hypermobility-related disorders are quite complex, and diagnosis should always be made by a qualified healthcare professional. So what is hypermobility? Hypermobility is a connective tissue disorder. And many people think of it as being double jointed or very flexible, but flexibility alone doesn't tell the whole story. Hypermobility exists on a spectrum. For some people, it's totally benign. They don't really have symptoms, and for others, it comes with pain, instability, fatigue, injury, and multi-system symptoms. So it's crucial to understand that hypermobility is not just about joints. It reflects differences in connective tissue, which is present throughout the entire body, including tissues involved in breathing, phonation, digestion, circulation, nervous system regulation, and so on and so forth. You'll often hear two terms, hypermobility spectrum disorder, or HSD, and hypermobile Ehlers-Danlos syndrome, or HEDS. And these diagnoses exist on the same spectrum. The difference lies in diagnostic criteria, not necessarily in the lived experience of the human. Both matter deeply in singers. So HSD is usually diagnosed when someone has symptomatic hypermobility, but that does not meet the full HEDS criteria. And then HEDS is a defined subtype of Ehlers-Danlos syndrome. And there are many types of Ehlers-Danlos syndrome. This presentation focuses specifically on HEDS, which is hypermobile EDS. Currently, as of today, which is January 2026, people are diagnosed using strict 2017 criteria, which is almost 10 years outdated. Fortunately, new diagnostic criteria is expected in the spring of 2026, so more on that later. And I will just reiterate that functionally, both HSD and HEDS can significantly impact singing. Regarding the diagnostic procedures and guidelines that will be upcoming, we're very happy about this because, in my opinion, the current systems for diagnosis are faulty and often used as an excuse to dismiss people's concerns. And so you can take a moment and read this slide, things that we're expecting to have come up soon to help us have better diagnostic criteria, which is going to give clearer guidance for doctors, more accurate and practical criteria for diagnosing, and also the incorporation of genetic and biomarker findings as these things emerge. So this is good news. So why do we need to know about hypermobility? This matters because hypermobility is common. It is frequently misdiagnosed or missed. It disproportionately affects women, surprise, and performers. It directly impacts tissues we rely on for singing, and many singers with hypermobility tend to be labeled as like inconsistent or unreliable or overly sensitive or in their heads, but actually their bodies are working much harder than average just to stay stable. Why are HEDS people called zebras? You'll often hear them referred as such. So this comes from a medical teaching phrase. When you hear hoofbeats, think horses, not zebras. And the idea is that clinicians should first consider common diagnoses, but sometimes the rare diagnosis, the zebra, is the correct one. So the EDS community adopted the zebra as a symbol because these conditions are often overlooked. Patients are frequently dismissed, and no two people present the same way, just like zebras. No two sets of stripes are identical. How common is this? It's estimated that 1 in 500 people have HSD or HEDS, and that it's more common in performers, but we think this is most likely underdiagnosed, and most experts agree with this. So why is it more common in performers? Well, Hypermobility appears more frequently in musicians, dancers, gymnasts, athletes. Why? Because flexibility is often rewarded, right? Due to the advantages, range, ease of movement. Sometimes this is even trained into the body. And in performers, hypermobility can be both an asset and a liability. So examples across the arts would be pianists and their very hypermobile fingers and arms, same with string players, very dexterous, or dancers, all of their joints, circus artists, gymnasts. And for singers, larynxes often yield, hypermobile larynxes can yield bigger ranges, sometimes huge ranges, easier agility and coloratura, ability to leap throughout the range with ease, etc. These are invisible illnesses, okay? So people can look fine, present normally, perform well until they don't. Pain and fatigue and dizziness and instability and all these other symptoms are not visible from the outside. And this invisibility can lead to a lot of disbelief from doctors, teachers, directors, and honestly, often from the singers themselves. But these symptoms are real, physiological, and not imagined. Here are a couple of graphics I've resonated with. The first gives you a glimpse into how multi-system HEDS can be, affecting literally the whole body. It can be completely debilitating for some or just a slight inconvenience for others. It is degenerative, and often a person's quality of life declines over time, especially if they are unknowingly exacerbating their symptoms. So let's get into the singer-specific reality. The fact is, there's very little research on singing and hypermobility. Most of what we know comes from clinical observation, interdisciplinary voice care, and lived experience. So many voice teachers already suspect hypermobility in students but lack formal education about it because it doesn't really exist. In many cases, even when singers are sent to a voice therapist, these clinicians also lack knowledge on the topic, and in some cases, unwittingly make things worse. And that's why this conversation matters. Both HSD and HEDS are collagen disorders, which is a major structural protein in tendons, ligaments, fascia, connective tissue. So when ligaments are overly stretchy, muscles must work harder to stabilize joints. And this leads to fatigue, chronic tension, pain, and this applies directly to the voice. And no, sadly, eating or drinking collagen or having collagen injected does not cure us. Nothing does yet. A few good to know terms as we move forward. The Baton score is used to assess generalized joint hypermobility and evaluates the flexibility of joints using a 9-point scoring system. My personal opinion is that the Baton score is overly simplistic and often used as a tool to dismiss, as I mentioned earlier, and we're looking forward to the new criteria. Another term to know is subluxation, which is common in people with joint hypermobility. It's a partial or incomplete dislocation of a joint, which can cause sudden pain, instability, a feeling of slipping or shifting or popping. Some people sublux all the time, and it's just part of their life. You'll often see these people wearing braces or special jewelry for their finger joints, and other people sublux rarely. You absolutely must know about POTS when we're dealing with hypermobility. It stands for postural orthostatic tachycardia syndrome, which is a form of dysautonomia, commonly co-occurring with HEDS. So when moving from lying to sitting or standing, the heart rate can spike, blood pressure can drop, lightheadedness, dizziness, brain fog, fatigue can occur, and of course, these conditions overlap with the physical demands of singing. And finally, let's be aware of MCAS, mast cell activation syndrome. So mast cells in the body release chemicals inappropriately in many HEDS people who have MCAS, causing allergy-like symptoms. So this can cause flushing, itching, GI issues, lightheadedness, tachycardia, low blood pressure, which can overlap with POTS, brain fog. So be aware that this is another very common symptom. Oh, and one more. Dysphonia is a good thing to know. This is the medical term for changes in voice quality that make it sound rough or raspy, breathy, strained, weak, quieter, etc. This is often from vocal cord issues like inflammation or improper closing. HSD and HEDS people suffer from dysphonia quite a bit. It can stem from overuse and injury, but often overall chronic body fatigue and conditions like hypermobility can cause dysphonia. All right, so the next part, I'm going to move quickly through a series of slides that are meant to illustrate the profound and expansive effect that HEDS can have across the whole body. So I will let you peruse this more carefully on your own. But I will let you absorb the enormity of this as I move through these slides. So joints that move too far, joint pain, subluxations, full dislocations, tightness of the muscles, pain in the muscles, spasms, etc. Moving on, skin and connective tissue, softer velvety skin, stretchy skin, easy bruising, translucent skin, hands, feet, and circulation. Raynaud's phenomenon, which is that real cold hands, feet condition, is very common. Pain in fingers or wrists, swelling in hands or feet, etc. Jaw, TMJ. So we can have jaw clicking or popping, jaw locking, pain while chewing, frequent headaches, etc. Obviously affects singing. Autonomic nervous system, we talked about POTS already. So feeling dizzy or faint, chronic fatigue, heat intolerance, cold intolerance, excessive sweating, all kinds of things can happen. And no one has all these symptoms. This is an example of types of symptoms that different people may have. So then neurological and nerve-related, headaches or migraines, tingling or numbness. Poor proprioception, which is important. We're going to talk more about that in a bit because that is very important for singers. Cardiovascular, heart palpitations, chest pain that isn't heart-related, early varicose veins, gastrointestinal, significant reflux, which of course is important for singers to note, abdominal cramping, IBS-like symptoms, etc., respiratory, shortness of breath, breathlessness, asthma-like symptoms, throat tightness or a lump in throat sensation, lots of postnasal drip can be a symptom, fatigue, energy, and sleep, needing more rest than peers, crashing after activities, trouble falling asleep, poor sleep quality, etc., pelvic pain, frequent urinary tract infections, pelvic floor dysfunction, etc. Okay, and mental health, of course. So anxiety is very common, especially with dysautonomia. People can have ADHD-like symptoms. We find that ADHD, autism, and ADHD are very common with HEDS. There's a lot of overlap that's being studied. There can be overwhelm, feelings of depression. And I have personally not met a person diagnosed with HEDS that does not have anxiety. So this is a very common symptom. Now, I'm sure all of you HSD, HEDS folks watching this may have noticed that there are symptoms missing, symptoms that you experience that could be related to your conditions. There are just so many, and we're all affected differently. But hopefully this gives an overview into the types of symptoms one might experience. So what can happen to singers? Many singers will say, some days I have it and other days I don't. And that inconsistency is usually physiological, not technical or psychological, right? So we can have persistent vocal fatigue disproportionate to use, significant reflux, which of course can damage the vocal folds temporarily, sometimes more permanently, but can cause issues within the folds. Healing can take longer in the case of injury. Also, some people have experienced ribs shifting or popping when taking a deep breath, so that's worth noting. Other things. So poor proprioception, I mentioned this earlier, is like, where is your body in space? And that can be really tricky because especially in the voice studio, teachers can rely less on how does that feel, which we all say all the time, right? And more need to focus on observable patterns and pacing and helping the singer understand where their body is in space. Use of mirrors, right? We have more ideas coming, but be aware that poor proprioception is very common. It's also harder for people to know that they are overly tensing their muscles. Notice that their muscles might be becoming fatigued. It's harder for singers to explain how they feel, okay? So changing things up, the way you do things might be important here. In and of the larynx, we can have voice cracking at random, hoarseness, sudden flips to whistle tone, which is interesting. Difficulty in the lower passaggio. We can have difficulty in all passaggi, but particularly the lower. Instability in the arytenoid cartilages, hyoid bone displacement issues, a large thyrohyoid space, and dysphagia, which means trouble with swallowing. So my own story, I will tell you briefly. About 2019, I was singing Carmina Burana. I'm a soprano. And when I was singing the high D in practice, I noticed one day that as I sang it, it had a little pop, and then the pitch stopped. And I thought, wow, I must have done something really weird. It felt good the way I approached it. I don't know what that was. Sang the concert, dress rehearsal was fine. A couple months later, I was singing Juliet's Poison aria, which has a C sharp, a couple C sharps in it. Same thing happens. I'm singing the note, feels great, feels set up properly, and then suddenly like a strange sensation in the throat. It didn't hurt, but it felt almost like a pop. I thought, huh, that's very strange. And then it started to happen a little more often. I started to get freaked out. So that's when I went and worked with a clinician named Tara Stadelman Cohen at the Voice Center at Mass General Hospital. And we determined that this was likely related to hypermobility. And we tried various things, including kinesiotaping the darn thing into place. We worked on overall body mechanics. We came up with solutions for the vocal fatigue I was experiencing, because from honestly 2017 on, I was experiencing more and more vocal fatigue, which was disproportionate to the amount I was singing. So the sad part was that as I sang, I kept my active singing career going and going, even through the pandemic, and I noticed that it was degenerating lower and lower. Sometimes it would happen on a C, then suddenly it was happening on B natural. And through a lot of work and study and curiosity, speaking to other pedagogues, I was able to create protocols for myself that have stopped or stalled the degeneration. It has been determined that the hyoid bone of my larynx pops out of place or subluxes. Okay, so the larynx is not a joint in that it doesn't attach to another bone. It's a floating bone, but it is a muscular joint, and the hyoid bone itself displaces. I also found that when I was scoped and sang very high in the scope, which is not very fun, that inside in the intrinsic laryngeal musculature area, my arytenoid cartilages were hypermobile and shivering and shaking at some points. So there was instability both at the hyoid bone and the arytenoid cartilages. The protocols that I created for myself, well, one, I barely warm up, and that's been a very big adjustment. But I have a far better likelihood of being able to sing for longer periods of time and higher if I don't spend a lot of time warming up, because I have limited vocal capacity for the day. I do not touch the larynx. I do not do heavy-duty laryngeal massage, neck massage, tongue massage. I used to do this all the time. In fact, I've studied manual therapy. I do this work with a lot of my students. It can be incredibly useful if you're not hypermobile. And I would recommend that, if you're hypermobile and you are regularly massaging and moving around your larynx and all around the vocal tract, that you get professional opinions and help with what you're experiencing before you continue that. I also use low level light therapy and red light therapy. So there's an article about that in the resources towards the end of the slides that you can check out. That has been very helpful to me, but finding the right device is quite tricky, actually. And then overall body strength has been huge for me. I went to PT for a number of years and saw physical, personal trainers and such, but it wasn't until I found a PT who specifically focuses on hypermobility and is highly trained in EDS that I really noticed how helpful that was. And that started to change the game for me. I also combined that with reformer Pilates, specifically, not mat Pilates, but reformer Pilates. And those two things have really made my body more stable. It's easier to be standing. I don't have as much pain around the joints. There are a number of other things that I did in order to stall the degeneration of what's happening with my voice. And of course, it's different for everyone. But I will say that managing HEDS in general is a lot. I've had to do, I have to do regular hot baths with Epsom salts and wear a hip brace if I need to walk more than a mile, use foam rollers and massage guns and ice and all manner of tools to manage chronic pain. Sitting in one position is really hard. Sitting through long operas or musicals can be very difficult. And sometimes I leave at intermission because it's just painful. Anyway, you get the idea. My story is one of many. And in the last couple of years, I've also been very intentional about what repertoire and what gigs are comfortable for me. So I work with composers to commission things that are really comfortable for my voice, or use ossia, which is optional notes in case I don't want to take the note that's written. I am very careful about what oratorio or opera I accept. So I have to be intentional and know my limits in order to keep singing and keep my career active at this time. There are minimal studies and very little research around this. There's one really big one. It's called "I Have Had to Stop Singing Because I Can't Take the Pain: Experiences of Voice, Ability, and Loss in Singers with Hypermobility Spectrum Disorders." And you can see the authors here. This survey was completed by 276 participants across Europe, America, Africa, and Australia. 156 identified as singers, and this study focused on 71 of them. Three big themes emerged. One is the unreliable voice, right? The ups and downs, the inconsistency. The other is the wider effects of HSD, HEDS on singers, body pain, how people perceive you, etc. And that need for acknowledgement and support, accommodations, people to understand what's going on and how to help you. So here are a few quotes. Sorry, I forgot to change the slide here. So take a moment here. This is just reiterating what I just said. So here are a few quotes from people in the study that I would like you to take a moment to read. I really resonate with this last one. Sometimes I feel like they can't see it's my voice that's unreliable, not me. I really hear this a lot from people who suffer from hypermobility. All right, so continuing on with the study, case reports have identified problems including subluxation of the hyoid bone within the larynx, reduced mobility of the arytenoid cartilages, or in my case, hypermobility of the arytenoid cartilages, problems with the structure or functioning of the folds themselves, hypotonicity, which means low muscle tone in the larynx, pharynx, and esophagus, as examples. So definitely check that out. That's one of the bigger studies that we have as a reference. More are on the way, and people are starting to pay more attention to this and realizing it's really quite common. And so many people are walking around not realizing that they have this, and that many of the things they're blaming themselves for all come back to the same issue here. As it turns out, every health problem I've ever had is all related to EDS. So I used to faint as a child. I have anxiety. I have Raynaud's syndrome quite badly in my hands and feet. I have POTS and heart palpitations and dizziness, and all these things that I've suffered from throughout my life are all related to one thing. So EDS is about prevention versus cure because we do not currently have a cure. So managing chronic pain and the prevention of further damage is so important. And so management has to focus on strength, movement, and functional training, pain management, taking care of your mental health and your nervous system, asking for and advocating for accommodations, right? General advice often doesn't apply, like just strengthen or just stretch. That's not helpful because we have to know how, right? And we have to know exactly what is going to be safe for us. And teachers out there, it is on you to push for accommodations at your institutions and to believe students. So, regarding strength, movement, and functional training, if you go to physical therapy, you really want your therapist to specialize in hypermobility. So I would rather someone work with a hypermobility specialist online if they live in a more remote area of the world or country. I'm in the US, in Boston. Than work with a PT who doesn't know very much about hypermobility. And some say they do, but you really want to get more information before you engage. I mentioned Reformer Pilates. I'll also talk to you briefly about the Monkey Body by Drew Ricciardi shortly. Tai Chi can be great. Alexander Technique, Feldenkrais, swimming because it's low impact, very good for strength. Yoga can be helpful, but it really does need to be modified and monitored by an instructor with hypermobility knowledge. That's super important. Regarding the Monkey Body, that's a therapeutic movement mastery program. Drew Ricciardi is a violist, classical violist, who has HEDS and POTS and MCAS and spent decades just not being able to solve the issues in his body. And after all these injuries and failed strengthening approaches, he developed a different way with working with the body that prioritizes safety and decompression and nervous system regulation. So this method is max 20 to 25 minutes a day, which is really important for EDS folks who can't do the normal amount of exercise, especially as they get older typically. And so being realistic and really maximizing on that time is important. And so the program combines gentle rocking, rolling, spiral-based movement, resisted decompression, and primal postures to support the body from the ground up. Drew's a great friend of mine. I think he's amazing. And this business is taking off because hypermobility sufferers are finally getting relief, finding something that works for them. And so perhaps instead of spending your copay money on a PT that's not helping you, this could be a good option. And there are more and more modalities coming out that may be more helpful for EDS people than your sort of run-of-the-mill modalities. What to do as a voice teacher. Number one, take an intake when students join your studio. You need to know if they are hypermobile, amongst other things, right? Do they have injuries? All the normal things you would ask, hypermobility needs to be part of that intake. Be aware that muscle tension dysphonia, MTD, and other vocal issues are very common. So know when to refer, right? If you are not a vocalogist or a speech language pathologist, know when to refer and find out as many resources as you can. Partially, you'll find this out from this lecture, as far as who to send your students to talk to, right? Because if you are not super knowledgeable about hypermobility, we need to be able to point our students in the right direction. See and hear them, validate them, normalize the situation. When you're in a lesson or in a dress rehearsal or in a performance scenario, help the student pause and assess if they perceive fatigue, right? Don't be like, oh, I notice your voice is getting a little tired, let's keep going, right? So we've got to take breaks, normalize breaks. That's really important because, again, vocal fatigue can be disproportionate to use. It can show up really easily. So then also being on the lookout for compensations, tensions, locked knees, ways that the body might move without the person realizing due to their poor proprioception, that is on the teacher to be on the lookout for. You can also consider shorter lessons, right? You could break it up 30 and 30. Normalize seated singing. You don't have to be standing all the time to sing, right? You can sing in other positions. You can do hands and knees, but get up quickly. Get up slowly. Don't get up quickly. Get up slowly from those positions. Sit in the lesson for part of the time, right? We don't have to be standing all the time, and it can be very exhausting for EDS singers. Sometimes people go to a lesson and come home just exhausted. And singers need to advocate for themselves. I'm going to sit for a while. Great, let's do it. As I mentioned earlier, the lower passaggio can be quite problematic and tricky, so we want to be able to work on bringing the lower passaggio, bringing the chest voice, the modal voice, up, practicing bottom-up training for more stability instead of solely focusing on top-down techniques. So both are important, but be sure as a teacher that you are helping bring modal voice up in a safe, easy, gentle way, because this can provide more stability for the student. Consider encouraging cross-genre singing, right? Some students might be more comfortable in genres where they can use a microphone. It really depends on what they're experiencing. And please teach singers how to mark safely, right? Especially helping them learn how to sing down the octave or sing more lightly in a way that doesn't create fatigue. Speaking the text over the music. These are all things that should be normalized and taught. Moving on. Do not do laryngeal manipulation massage, especially not without the involvement of an SLP knowledgeable about hypermobility. So just be very careful with all of this with your student, as I mentioned before. Be super careful about repertoire assignments. It's better to start with comfort and choose rep that showcases the student's strengths versus pushing the voice to the limit. That is not a good idea. And some singers want to do that, so you may have to help them understand why that is not the best way to go. Teach singers how to do more armchair work, right? That's the IPA and the character research and the watching the recordings and all of this type of work where we can speak the text in rhythm and spend less time standing and doing labor-intensive things vocally and physically, but do more sitting in your armchair. You can use resistance bands around the singer's bodies or rib cages in creative ways that I'm sure you have many ideas for to help with proprioception, kinesthesia. I like to use a Bosu ball. That's the half ball. It's flat on the bottom and squishy on the top, or a balance disc to help students activate their inner core, particularly the transverse abdominal muscle, to help with overall core stability when they're singing so that they're not dumping into other parts of the body and over bracing and locking in other areas. So that can be a useful tool. Recommendations for singers. There are a number of really cool tools out there. Some of them are very expensive, be aware, but that can help the bodies of hypermobile singers throughout the day. There's a jelly bend, which is kind of like a garment that you pull up. It's sort of like a corset. It's like slipping on a pair of abs is like their catchline, their catchphrase. Body braid is a thing that sort of wraps around all the joints of the body. You can wear compression garments or braces or fitted shapewear corsets that can help create stability, alignment, circulation, and comfort. Shorter warm-ups and practice sessions. Like I said, I warm up almost not at all. So I really minimize that. And it is a trade-off, because while I walk into performances sometimes being like, wow, it's really weird to sing this without being warm, and I might not sound as awesome as I want, it's better than my larynx popping out on a high note. So I have learned the protocols that keep me able to perform my best. And for the most part, I have found that HEDS singers don't require as much warm-up time as other singers because of the hypermobility. So just keep that in mind. Circulation tends to be better in the afternoons in people's bodies. So afternoon lessons or coachings or practice sessions might be better. Core strength is crucial, like we talked about. Shoes matter. So figuring out the right shoes to help you not lock your knees, to help you with your hip pain or whatever it is you're experiencing. Choose carefully. Get inserts if you need inserts during the day in your regular footwear. Think carefully about what you're going to put on your feet when you perform. And then before you sing, only stretch your body in ways that are deemed safe by your care team, right? Stretches that are useful for most people often make things worse for hypermobile people. So we have to be careful about that. Hydration is very important. Hydration with electrolytes is recommended. Salty snacks, especially for people with POTS, and sugar for people with hypoglycemia. So depending on what your symptoms are, be sure that you know what is going to be helpful. Discuss it with your doctor. Exploring low-level light therapy. Again, you'll see the article in resources. I put the red light therapy right up against my larynx, and this helps with my vocal fatigue. I usually do this for like 5 minutes prior to singing, 5 minutes at intermission, and 5 minutes after singing. You can create your own protocols with the help of your care team, but check that out. Using amplification, if you're a classroom teacher especially, that's just a no-brainer, right? So we don't want to fatigue our voices further and then potentially cause damage when we can simply amplify. And resting your voice as often as possible. So I've put here selected resources and references. So here we have medical and advocacy organizations, websites, podcasts, and more. I highly recommend you hit pause and really take down some of these names or screenshot so that you can go in and actively look at all of these different resources that are so helpful. I especially love the work of Joanne Bozeman and Marita Stryker in the Chronically Singing website. It's full of resources, so definitely check some of this out. Books that can be helpful, not just for singers with hypermobility, but for people with hypermobility in general. I have read almost all of these and found them extremely helpful in navigating my own diagnosis and lifestyle with EDS. So closing thoughts here, you do not have to stop singing. You can even be a full-time performer depending on what it is you're experiencing. As long as you're educated, you advocate for yourself, and you prevent issues before they start, right? This is about prevention, not cure. And so knowing how to treat the symptoms that you currently have and prevent further issues, further damage is so crucial and so important. So thank you so much for joining me for my lecture on hypermobility. Again, I'm Dr. Lynne Varga. My business is called The Empowered Musician. Please follow me on Instagram. I'm also a career coach for musicians. So I'm a voice teacher, performer, and career coach for musicians. You can check it out at theempoweredmusician.com and find me on the socials. And I hope this was helpful. I would be more than happy to work with you one-on-one in my hypermobile singer consults. If you are someone who is a singer and wants to really kind of spitball what you specifically need so that we can tailor that and figure out what your care team needs to look like, what interventions you need, what accommodations, etc. So you can find that information in the details below. And thank you again for joining me. Have a great day.